nursing and medicine, we have a lot of Greek and Latin words. And if you can start to break them down, you can kind of figure out a little bit about what you're talking about. And I'm thinking of this mostly for the NCLEX. So if you learn some of the typical prefixes and suffixes, like itis, you know what itis is for, it's an infection. So we have a lot of them in this area of nursing, and one is antepartum. Anytime you see partum, you're going to think childbirth of some sort, okay? So you have something about partum, think childbirth. Ante is a prefix meaning what? Before. Before. So anytime you see the word ante in front of something like that, it's going to be prior to or previous. So this is before birth. Next week, you're going to talk about intrapartum. So that means intra, in the midst of, in the middle of birth. So that's going to be labor and delivery. The week after that, we're going to talk postpartum. So that's going to be after the fact. So just keep those things in mind as you're studying for NCLEX, because it might clue you in and just the light bulb might go off if you can break it down a little bit. Right? Do I have no battery? I have no battery. What happens from November to December? All right, I'm going to stand back here then. I apologize. I'll get a battery for next time. Okay, so antepartum. Here's our objectives. Remember I said I put our objectives up here. So today, we want to be able to compare the presumptive, probable, and positive signs of pregnancy. Describe the nursing interventions appropriate to the expected physiologic and psychological changes of pregnancy. Describe the care of the pregnant patient at her initial prenatal visit. There's another one, prenatal. Natal, again, having to do with childbearing. So pre is before childbearing. So prenatal is going to be before she has the baby. Postnatal will be after the baby. And her follow-up visits. And given the date of her last menstrual period, abbreviated LMP, you're going to calculate the due date. Then given her OBGYN histories, you're going to determine her gravidity and parity. You're going to teach her how to manage some of her common pregnancy discomforts, analyze risk factors that she might present with, and then consider developmental level and cultural background when planning her pregnancy care. Okay? Hopefully that all makes sense. So, when somebody thinks they're pregnant, whether it was you guys, your partner, or somebody you know, what makes you start thinking you might be pregnant?
Absence of breast tenderness.
Breast tenderness. This period. Anything else? Urinary frequency. Oh, you're looking at it, aren't you? Vomiting, nausea. Right. I'm trying to think in the real world. Right. Amenorrhea. So that's generally where you first start thinking either yippee or uh-oh. And they're signs, but they're not the most foolproof, reliable, 100% proof positive signs. And we call them presumptive, presuming. So you know when you presume something, you're kind of making a decision about something with not a lot of evidence. That's how we group these signs. So her amenorrhea, and again, here we go again. A meaning lack of, when you're looking at Latin words. So lack of menorrhea meaning menses. So she has no period coming every month. She's nauseous, she's vomiting, she's tired, very, very tired. Urinary frequency, breast enlargement and tenderness. And quickening is the word for when she first notices the baby's movement. So all of those things, if you're pregnant, you're going to have them. But you may have all those and not be pregnant.
Except quickening.
Huh? Except quickening. Except quickening. Right. But quickening in a first-time mom, many times they think that's just, I mean, really it is just gas, and they're trying to tell you it's quickening. So that's an iffy one. So I bet many people in this room have a lot of those symptoms now just coming into this class.
I think it's one of them.
Yep. And then next week before the quiz, there'll probably be a little more. So the point is, all those symptoms have to happen with a pregnancy, but they can also happen with a whole lot of other things. So we would not have our patient come in and she reports all that to us. Oh, congratulations, you're pregnant. we wouldn't do that. We would do a little bit more assessing first, right? So we'd have a foolproof decision for her. So then we've got signs that are probable, that you're probably pregnant. These are a little bit more objective. They're a little bit more solid, and they're physical. That most of these are something that a professional would see on an exam, and we'll go through a few of them. The Dell sign is the general area, her cervix particularly, but really the whole perineal mucosa down there, becomes more bluish. Now, as we're going to talk today, she's going to be making a whole lot more blood in her body. She's carrying a lot more blood, and particular certain areas are going to show the effects of that by taking on characteristics of color change. They're going to get a little bit more bluish. They make it a little bit more softer because they're puffier with all the extra fluid. Okay? So that's what happens here. Her cervix looks a little bit more blue. When you do your exam and you put her up in the stirrups and you put the speculum in and you're eyeballing that cervix, it's going to look blue to you. When you just look at the vaginal tissue, it's going to be blue too. You're also going to, when you go to examine the cervix, it's going to be squishier. It's going to be more soft because it's full of fluid as opposed to a firmer tissue. The Hagar sign, again, contributing to the changes in her, let's see, I don't even have my pointer now. The uterus is the circular thing with the baby in it, then the thing coming down there is her cervix. So the uterus and the cervix are connected. Generally, that connection point is very stable and it doesn't move. When she becomes pregnant, everything gets a little bit more flexible because of the hormones. So now when you're going to do the exam, you can flex that cervix. And that is the Hagar sign. That this area, this isthmus, which is where they meet, is just more flexible. So when you're the professional and you're going in and examining this possible pregnant woman, you're going to see this kind of stuff. Ballottement, same thing. When you are in there doing her exam, if you tap the uterus, this sounds very cruel, but you can bounce the fetus in the amniotic fluid, and then when it falls back down, you feel it on your fingers, and then you tap it again, and it floats up here, and then it falls back on your fingers. That's called ballottement. It's basically bouncing the amniotic fluid with baby in. So you can feel that. That's another indication that she's probably pregnant. And then a positive pregnancy test. But all of these things could be caused by something else also. Some diseases or some hormonal changes. Even the positive pregnancy test, it is not 100% reliable because there's always user failure and test failure. There are situations, some tumor type situations that can give off that HCG that makes a positive pregnancy test. So all of those things, a lot more confirmation for a pregnancy than the presumptive signs, but still not 100% proof positive. We would have to tell her it's looking like you're probably pregnant. The only ones we've got that are positive, right here. This will confirm a pregnancy. If you hear fetal heart tones or fetal heart rate, we use that word interchangeably. So you're going to be listening with your Doppler, and you're going to hear the fetal heart tones. You, as a professional, are going to diagnose fetal movements. Because depending on the mom, and if she maybe doesn't have a lot of adipose tissue, her peristalsis, I'm sure you've seen this in some of your older population, you can see the peristalsis in people. So some people may label that fetal movement and come in and tell you the baby's moving, and it's totally not a baby moving. It's something else going on there. So a professional that is assessing and diagnosing fetal movements. Or the gold standard would be the ultrasound. We actually see a baby on a screen. And we can do it either by an abdominal scan, which is the old-fashioned way. We put some mineral oil on her belly and scan across this way. Or in the last couple decades, we've had the transvaginal probe, where it goes up into her vagina right next to that uterus, and you get a totally different perspective. Okay? So that is the only way to tell her she is truly pregnant. Now let's see what happens to her during this pregnancy thing. And anybody that's been pregnant, feel free to chip in about the lovely, again, I don't have my pointer. I had a laser on this thing. All right, so let's see. When we're not pregnant, our uteruses are about this big, kind of like a solid, with just a tiny little opening in the middle, and they live down in the pelvis. As they grow with the pregnancy, it stays in the pelvis, the wall stays in the pelvis, and then it starts to grow upward and become an abdominal organ. It also grows out front, but it's going up and out. So you can see the size of the baby growing and growing and how her belly gets bigger. Now over here at 40 weeks, the baby's very up close to her xiphoid process, and then it says after lightning. Well, that is not being struck by lightning that the baby moves. Lightning is when the baby starts to drop into the pelvis to prepare for delivery. So up to about 38, 39 weeks, her baby's pretty high, gives her some uncomfortableness in terms of eating and breathing, and then you'll hear people also say the baby's dropped. It's another kind of layman's term for it, where the baby just, all right, it's getting close to delivery, so I'm moving down into the pelvis. So the baby physically changes positions, which gives her a lot more relief up here, but then it makes her bladder quite compressed. So that is kind of an eyeball how the baby goes. I also want you to look at her sacral area with this. What changes? Or does it change? Or
It is.
what changes? Or what happens?
The breast.
No, we're talking about her sacral area.
Her spine.
Lordosis. Lordosis. It gets much more exaggerated curvature back there, which, as we'll talk about, is one of the reasons she gets a pretty severe backache. All right, here's another visual that may help. This is our unpregnant lady. Everybody see that? Our unpregnant lady. Here's our little uterus down here, where obviously there is a hollowing in the middle, but it's mostly thick tissue. Comes in here in our vagina, and this is our cervix. Here's our bladder. Here's our rectum, our intestines, so on and so forth, our stomach. So now we've got conception, the baby is starting to grow. So this is all happening unbeknownst to her. She's not feeling any symptoms down here. She's not really feeling any change in her anatomy. And baby gets a little bit bigger. And my opinion when I look at these things is where the heck are her intestines going?
What week are we at?
This is not by weeks. This is just a general progression. They did not measure these on here. I would say this was probably about 12 weeks, if I had to guess. Then we're still moving up. So here's our baby and our uterus. Here's our cervix. And we're going to talk in a minute. The cervix clogs up with mucus as a protection for the baby, because when we're not pregnant, technically there's an opening from the outside world up through our cervix into our vagina. But once you got a baby growing in there, we don't want the outside world to have any access to that baby. We want it to be sterile. So as a protection, the cervix will start to secrete mucus and clog it up, and that's called our mucus plug. So we've got our mucus plug in place. Here's our vagina. Our bladder is getting compressed. In this first trimester, as this is happening, again, baby hasn't started to go high up as much. It's sitting down here and it's starting to go out. Her bladder gets very compressed. So whoever mentioned urinary frequency as an early indication of pregnancy is right on. She doesn't hold much, so she's going to the bathroom quite frequently. So then we're growing. Baby is, this is probably maybe, I don't know, 24 weeks or something. The middle trimester, the baby goes up. So it kind of comes off the bladder. All that pressure she's feeling down there gets relieved. So we've got a little bit more bladder capacity. We've still got our mucus plug. Everything's there. Baby's growing bigger. Shoving the intestines, who knows where. That's why this woman has a hard time eating, because she can only eat small meals. Why she has constipation issues, because everything is compressed and not moving as freely. It's generally uncomfortable. Now right here is her umbilicus. We're going to learn in a few minutes that at 20 weeks, most women's uteruses are up to their umbilicus. And that's usually the midterm of the pregnancy. A pregnancy is 40 weeks or 280 days. So usually about 20 weeks is where the top of the uterus, which is what we call the fundus, at 20 weeks, the fundus is usually at the height of the umbilicus. So this lady is a little further along than that. But you can see that baby is taking up quite a lot of her abdomen. So now we're really growing. world, and here he is. He's coming up. The xiphoid process would be about here. He's come up. He's pushed all the intestine somewhere else. Still middle trimester because you've still got a fair amount of bladder capacity. He's still moving up and up and up and up and up. All right, now this is the third trimester. Our bladder is really compressed now. She can't hold much in there at all. So she's going quite frequently. She dribbles incontinence a little bit. She then, as an effect of that, stops drinking, which we want her to drink, but she doesn't want to be up going to the bathroom all night, so she's inclined to stop drinking, which isn't good. Plus, her stomach's up here and can hardly hold anything at one time, so it gets to be quite a problem for keeping this lady hydrated. And then this is just an outside-in looking at the uterus, that it's a muffle, and it's really only held in 4 spots. It's just kind of hanging around in there. I don't know if anybody's ever thought about their uteruses. But when it gets this big, you have these 2 round ligaments coming. They're attached back here, and it hangs from them. And then it's got 2 smaller ligaments that it hangs here. And some women get intense spasms of these round ligaments, and it's very, very painful. And again, why does she get a low backache? Well, we've already changed the curvature of her spine, and now we're hanging most of the weight of the uterus right back here. So any of you guys that have had babies, did your backs bother you? Yeah.
No, but I got sciatica.
Ooh. Yeah, very uncomfortable. Imagine this woman who's a nurse and working her 12-hour shifts on her feet for 12 hours, moving patients and things like that. It's not easy. She would need a lot of counseling by the nurses about how to get through that 12 hours as comfortably and safely as possible. So let's look at a little bit system by system, how this pregnancy is going to change her. So we mentioned her uterus becomes an abdominal organ. It goes from maybe, and not that important, but about a 10 cc capacity to 5 liters. Just to give you a general idea of the change in this organ. At 12 weeks is when it starts to rise out of that pelvic area and enter into her abdominal area. So usually about 12 weeks we can feel it right above the symphysis there. The walls get very, very thin. Remember, it was a fairly solid organ. Those muscles just stretch and get very thin walled. But they get very strong. And that's what that's showing you up there, the muscle tissue. It's very strong and supportive, but it's very thin. It gets a lot of blood flow to it, because think about this. The uterus is going to have the placenta attached to the inside of the wall, and it's going to have to pass back all the blood and waste products between the fetus and the placenta. So it needs a lot of blood going there. So now 20 to 25% of her cardiac output will go directly to the uterus. Okay? Now her cervix, as we mentioned, changes because of all the extra blood going to it. So it has that bluish color, and it becomes softer when it's palpated, and it forms some mucus plug. The whole area down there becomes an increased vascularity. So the whole area will take on a more bluish color to it. She gets more vaginal discharge. Now most women have some type of vaginal discharge. It's a mucous membrane. So it's going to be moist and have some moisture and discharge from it. Well, these moms get quite a lot of extra of that for a couple reasons. One, it changes to a more acidic environment. So it's going to hopefully deter the growth of organisms. So it's a protective factor. And it's also kind of like a washing out factor. So if it's dripping stuff out, again, a deterrent for any organism that's trying to crawl its way in there. So it's a protective mechanism that she gets the increased vaginal discharge. It is a very sugary sweet area. Women that are pregnant have a lot of extra glucose floating around. Glucose is glycogen. So she's got more glycogen in that area that is very inviting to organisms. And particularly if she's a mom maybe that has developed the diabetes of pregnancy, she is just one big candy factory, and it's very attractive. Plus, think about our yeast, which is a problem for her. They like warm, moist, dark, wet areas. Think of athlete's foot, jock itch. They thrive in those areas, and that's what this mom is going to now be breeding. So the glycogen encourages the bacterial growth, which is why Mother Nature then kind of increased the acidity of the discharge. Make sense? Yeah. Good. Yeast infections again, can be a problem for her. I just described what kind of places yeast like to live in. That's a perfect environment. So, again, we all have yeast in our body. Sometimes it just gets the opportunity to overgrow and take over. So her ovaries. The ovaries are the organs that release the eggs that got this whole thing started. Well, once she's been fertilized, she doesn't need her eggs released anymore. So the ovaries kind of shut down that production. And the follicle stimulating hormone and the FH that were responsible for that monthly egg every month, they don't need to do that anymore. So they kind of take it easy and step away from the scene. And the two big hormones we're going to be working with are estrogen and progesterone. Estrogen is kind of like an enhancer of many of the cells. The progesterone is a smooth muscle relaxer. So her ovaries now are not going to be secreting the every monthly secretions that we need to have an ovulation. What they are going to do for the first few weeks is secrete that estrogen and progesterone to support the pregnancy. So eventually, after about 6 to 7 weeks, the placenta will do that job. But in the first 6 weeks, the placenta's a teeny tiny little thing, and it's growing, it's growing, it's growing. It needs progesterone and estrogen to grow. So that's what those ovaries are doing for the first few weeks, and then as soon as the placenta is big enough and capable enough to secrete those hormones, the ovaries just kind of go to sleep, and they're not really a part of the pregnancy. The breasts. We mentioned they get uncomfortable. They get bigger. They are gearing up for lactation, which is the way that Mother Nature intended the babies to be fed. So the breasts start that process very early in the pregnancy. So they increase in size because the glands and the ductwork that's already there are getting bigger, but they're also increasing in number. So you're getting more glands, more ductwork, and then the ones that were already there are increasing in size. This process is kind of uncomfortable sometimes. So you also have more blood going there, because if they're going to be making milk up to sometimes, I don't know, she could make a gallon a day sometimes. They need more blood supply to bring the nutrients there, so it's going to increase in vascularity. So just like we saw the change in color in the perineum, the breasts are going to change, that the veins there are going to get much more pronounced in many women. So you're going to see railroad tracks of veins, and that can be disturbing to her. You know, she might think something's wrong. Very common, very normal. Her nipples and her areola are going to get darkened as a result of some of these hormones. Her pigment increases in very many places. Her axilla, her perineum area, the line up and down her abdomen, increase in color and darkness. The thought is that that's supposed to help the baby see the nipple when they're first born. Who knows? And then colostrum could start leaking from her breast. Colostrum is the first milk. It's that very high, rich, antibody-rich fluid the baby gets for the first few days. Well, it could start leaking in the 3rd trimester. So if you have a mom that's about 7 months and something starts leaking from her breast, she might call you in a panic if nobody's told her about this. Because what are we taught when we're doing our mammograms and our breast health and things like that? Discharge bad. Discharge bad. So again, that can be part of our anticipatory guiding her through this pregnancy, and you're going to find that that's a lot of the focus of this 9 months that we have her for. Sure, we're checking blood pressures and we're dipping her urine and things like that, but we've got this woman, she's our captive every month, and we've got to make the most of that time to be educating her about what is coming to keep her anxiety down and keep her functioning at her optimal level. Blood volume. Mentioned, it increases. It's one of the reasons these pregnant women are always so warm. If you ever had to live with one of them, they're always turning down the heat and turning up the air conditioning, and people are frozen out. My husband used to call me Nanook of the North, because I would always want to turn the air conditioning higher. So the volume increases about 40 to 50%. That's a lot more blood. So it is going to have an effect on her. What happens, and what's interesting here though, it doesn't increase uniformly between plasma and cells. You can see up there, the plasma increases about 1,000 millimeters. The red cells only increase about 450 milliliters. So that's about a 50% increase in plasma, about 30% increase of cells. So it's a little bit off balance. So what is that going to look like to us when we go and draw our H and H? It's going to be low, because we've got some dilution going on here. So we need to know that, to expect that. So when she's pregnant, her H and H's are going to be a bit off. Generally, the rule of thumb is expect about a 7% shift. 7%. You know that it might drop. I mean, we don't want to drop it down to the teen. So about 7% shift. Now, the caveat for that is, you know, we can expect it to go down her hemoglobin to 10. Wouldn't be great. So we say if it's less than 10.5, it's a bigger problem than just this physiologic anemia. If it's 10.5, if it's less than 10.5, we've got some iron deficiency anemia going on, and she will need to be supplemented with iron. But yeah, her hemoglobin could go down to 11 to 14, something like that, and be fine. But less than 10.5, we usually think that's something that needs our attention. But if we did need to give this woman some iron, what do we know about giving iron? Flashback. You. Constipation. Dark stools. Anything we want to do when she's taking it? Stool fiber. How about, what do we give it with?
Orange juice.
Vitamin C. Vitamin C, orange juice, remember that. Or if she don't like orange juice, find her other sources of vitamin C. It just helps its absorption more readily. So again, you may have someone that doesn't need, you know, because they're all going to take prenatal vitamins, which will have extra iron in it. But if this is a woman that goes even below that, maybe she is having really severe nausea and vomiting and she's not keeping anything down. She may be one that needs a little extra iron. Maybe she is not the best nutritionally able person. She might need a little extra supplementation. So, yeah.
So how likely is it that we would actually be giving vitamin C with it versus they be prescribed something that has it, iron with the vitamin C?
Depends on your physician. Depends on your physician. But again, when we're talking up here, we're talking about anybody could be working out in a rural clinic versus to the highest state-of-the-art metropolis. It's just good for you guys to get in your mind that iron, vitamin C. Okay, her blood clotting factors, her fibrin and things like that, they increase in this woman. What might be a problem with that we would tell her about or we would be checking for? Thrombosis, DVTs, right. So she's more likely to get them. And then as we talk more about the changes in her, you'll see she's got even more reason to be a candidate for that. Any questions so far? You guys are so quiet. Do you need another break? No? Okay. It's just riveting material, right? So her cardiovascular system, some changes there. Her heart, we saw what happens. Everything is being pushed up here. Well, her little heart's about here, so that's going to be pushed up and off to the left a little bit. It also enlarges. It's got to handle all that extra blood and that increase in her cardiac output. So it's doing more work. So it enlarges and it gets shoved up and to the left a little bit. Cardiac output, we mentioned, increases by about 30 to 50% by 32 weeks. That's a lot. And remember, the cardiac output is the stroke volume times the amount that comes out. So everything is working much harder than it was before she was pregnant. So her heart rate increases a little bit too, so you wouldn't get too concerned if you had a heart rise. But that's where, again, the critical thinking, if you're working with her during her pregnancy, you're taking her month to month to month, and you see something's happening about month 7, you've got all your data from the first few months, and you're constantly reflecting back. What was she when she first came to us? How are her vital signs and her situation changing? Is it within the norm that I expect, or is she a little out of the norm that we need to do a little bit more assessing? Her blood pressure. Now, one of the things that progesterone, remember, we've got 2 big hormones going on. We've got others, but the 2 biggies are progesterone and estrogen. One of the things progesterone does is relax her smooth muscles. And we'll find that it's needed, but it can also come with some ramifications. So her blood pressure in the first trimester is usually what we expect it to be as it was when she came to us. In the middle of the pregnancy, in the middle trimester, it drops. And part of that is the result of this progesterone. It's relaxing her vascular system. So if there's not a lot of resistance and tone in the vessel wall, it's relaxing, so you're going to get a little bit of a lower blood pressure. And then that effect changes, and in that last trimester, she goes back to her regular pre-pregnant blood pressure. Okay. This relaxation of those vessel walls is also affecting her whole system's vascular resistance. The whole system's vascular resistance is going to be less. Okay? Yeah, Jimmy.
Would the decrease in blood pressure affect the perfusion to the placenta?
Say it again.
Would the decrease in blood pressure affect the perfusion to the placenta?
If it went too low, it would, but this normal shift is not too low. Yes, if it went too low, you're right, you're not going to get enough perfusion to the baby. But this is expected, and the vessels are a little bit more floppy, but they can hold more blood because they have that expandability. So her systemic vascular resistance all over her is less. So we were talking back here about, what were we talking about? Oh, the DVTs, the DVTs. So we already said she's a little bit more hypercoagulated. Well, now it's going to be a little bit harder for that blood to get back to the heart because everything is so kind of loosey-goosey and lack of tone. So the blood is going to hang out down there more. So again, a little bit more indication of why she might get a DVT. Okay? Then let's throw on top of that this big old uterus sitting here. So you got this baby that could be 10 or more pounds. You've got a uterus that weighs X amount of pounds. You've got amniotic fluid, placenta, a lot of weight right here. So it's sitting right on these major vessels. So again, we've got another indication of why the blood is going to be hanging out in her lower extremities longer than we'd like it to, which is predisposing her to those DVTs. Okay? Along with her cardiovascular system, everything getting a little loosey-goosey, we also have that growing baby that if she lays there on her back, her big vessels, her aorta and her inferior vena cava, if she lays on and takes this big, let's say up to 20 pounds, and just lays, what's going to happen to these vessels? They're going to be compressed. Exactly, they're going to be compressed, which is, going back to Jimmy, going to decrease the perfusion to the baby. So we're smashing those vessels, so we don't have as much blood getting around to get to that uterus and that placenta to give the baby some oxygen. So as soon as this woman starts to get an abdomen that is showing, we're going to ask her to spend her time on her side and not her back. And we prefer the left side. As you can kind of see up here, when she's on her back, baby smack on the vessels. When we put her over on her left side, the weight of the baby is laying on the bed, and the vessels can flow uninterrupted. Okay? And the left side is preferable because the vessels are a little bit more off to one side.